Hello, everybody. Welcome to the webinar, Reduce the Risk of Cardiovascular Disease Through Prevention, which is offered by the Montreal Heart Institute Foundation. We are glad to have you here today and glad to offer you this private and exclusive opportunity to attend this webinar. I would like to hand over the floor to your colleague, Joy, who would like to address you a couple of words about the BNC.
Hi, everyone. Thank you very much. So National Bank is a long-standing partner of the Montreal Heart Institute. The bank has been an ally for more than 40 years and is today one of its most important donors. In 2020, National Bank made a $1 million donation dedicated to the prevention unit. We are pleased today to welcome you to this conference to promote cardiovascular disease prevention as part of Heart Month. We would like to especially thank the foundation and in particular Dr. Philippe L'Allier for making himself available today so that our employees across Canada can benefit from the most recent research in this field. Have a great time at the conference.
Thank you, Joy. We truly appreciate. Please allow me to introduce you Dr. Philippe L'Allier. So Dr. Philippe L'Allier obtained his medical degree at the University of Sherbrooke in 1992. He then continued his training in cardiology at the University of Montreal, followed by a subspecialization in interventional cardiology and clinical research at the Montreal Heart Institute and the Cleveland Clinic in the United States. Dr. L'Allier started his practice at the Institute in 2000. During his practice, he acted as head of the coronary unit, head of the interventional cardiology, and head of prevention and rehabilitation. In September 2022, he was named Director of Cardiovascular Prevention and Rehabilitation of the Montreal Heart Institute. His main clinical and research interests are atherosclerosis and hypertrophic cardiomyopathy. As a full clinical professor at the Faculty of Medicine at the University of Montreal, he actively participates in the training of residents and fellows in clinical cardiology, cardiovascular prevention, rehabilitation, and intervention. He is also a guest speaker on national and international forums. Among other things, Dr. L'Allier works at the EPIC Center, which contributes to the promotion of health and the acquisition of healthy lifestyle to prevent the risk factors associated with cardiovascular disease. Before we start, I would like to inform you that the webinar is recorded and we will gladly share the link with you. However, we will not be sharing the PowerPoint presented by Dr. L'Allier. Dr. L'Allier, please go ahead.
Thank you very much for the kind introduction. So thank you very much for your interest and thank you very much for participating in the webinar. So without further delay, I will start. So first, I would like to start with a question for you. So the real question is, what does being healthy really mean? So interestingly, the World Health Organization provides the same definition since 1946. Health is, in fact, more than just the absence of disease. It is a state of complete physical, social, and mental wellness. So what does it really mean? It means that we need to think about it in a general and broad sense, as opposed to a very focal and medical term. So the World Health Organization also identifies optimal health as a fundamental right. So this is very important globally and with regards to how we see health in the global perspective. So cardiovascular disease, this is the focus of our presentation today. The key facts provided by the World Health Organization mentions that cardiovascular diseases is in fact the leading cause of death globally. It is estimated that 17.9 million people die from cardiovascular diseases in 2019, and it does represent approximately 32% of global deaths. So this is really the enemies. First, atherosclerosis, which is the disease characterized by accumulation of lipids, cells, and calcium in the wall of the coronary arteries and the arterial vessels throughout the body. And also atherothrombosis. This is a complicated word to mention that there is a blood clot that can form on these lesions. This is the disease that causes conditions such as angina, unstable angina, myocardial infarction, heart attacks, heart failure, sudden cardiac death, and stroke. So in the last few decades, it is very much the same in Ontario and the rest of Canada, and it is the same in the province of Quebec. We've developed systems of care to address the issue of acute myocardial infarction. We have identified cardiovascular interventions as being the optimal way to treat heart attacks. And in fact, if you have symptoms compatible with heart attacks and you call 911, typically the emergency care, pre-hospital care, will actually go to your home and perform an ECG in your living room. If the ECG qualifies as a heart attack, you will be directly transferred to a facility that is able to perform these high technology interventions in cath labs and being able to open up the artery that is closed by the blood clot and eventually save your life and save the complications. Of course, if the systems of care are so efficacious and well organized, why should we try to prevent cardiovascular disease? Well, because it is largely feasible through healthy lifestyle. This is one of the, of course, main reasons. The second reason is the fact that it cannot be cured. The cardiovascular diseases typically can be somewhat controlled, but they become a chronic disease once you have the condition. Thirdly, often there are no warning signs before a heart attack. So you cannot have the opportunity to seek medical care, for example, to try to prevent a heart attack. The first news you may have of this condition might be a heart attack. And lastly, worse even than a heart attack, the first sign of this condition can actually be sudden death. And this is partially the reason why people present, and some people maybe you felt or heard or have even someone in your family who actually died suddenly. This is, of course, a catastrophic event in families and in the life of someone. And because this is the situation, prevention needs to be considered as a very important goal of treating this condition. So what are the classical risk factors that lead to this condition? These were identified in large cohorts, such as the Framingham Heart Study in the suburb of Boston a few decades ago, which identified a number of risk factors. The major ones are listed on this slide. Of course, there are two non-modifiable risk factors. There are the age of someone and family history of premature coronary artery disease. And of course, there are four modifiable risk factors. They are smoking, they are hypertension, lipids, and diabetes. Of course, the way we address smoking is through counseling, nicotine replacement therapies, some medications are available. And of course, we even go to recommend e-cigarettes in the context of limiting the risks of smoking and quitting smoking. Hypertension, a special diet called the DASH diet is very recognized in this field, lowering the consumption of sodium. And of course, there are numerous medications that are quite efficacious to lower blood pressure, and they should be used in a sequence that is determined in clinical guidelines. Lipids, they are also typically treated with medications, and namely the statin category of medications. This is very prominent, and lots of people take these medications. They are quite efficacious. Nutrition, and of course, why is this important? If we have effective medications to lower lipids, it's because it is quite important to do two things. One is to decrease the amount of lipids circulating in the blood, and second, it's very important to limit the way the interaction of the lipids circulating with the arterial wall. So the quality of the lipid, whether the lipids are sticky in the arterial wall or whether they actually just perform their normal physiological activities. So this is influenced by nutrition mostly, the quality, and the quantity is mostly influenced by the medication. So why have I put diabetes in bold letters? It's because it is the one risk factor that is mostly increasing in the last few years and even decades. We are now at a situation where the CDC, for the Center for Disease Control in the US, it is very much the same in Canada, they actually have identified that there is about 11.3% of the adult population that has a diagnosis of diabetes. And there is an additional 38% of the adult population that has pre-diabetes. So this is a total of 50% of the adult population that has an issue with glucose management, so sugar management. and it's expected to increase over the next few years. And the major risk factors for people with diabetes, and major consequences of having diabetes, is cardiovascular diseases. So there's a strong link between diabetes and cardiovascular prevention. So what is the actual relative contribution of the classical risk factors we've just mentioned? They are basically associated with a 2 to 4-fold increase in the risk. And very importantly, these risks are essentially additive in the sense that if you have 1, 2, or 3 risk factors, they are actually added to one another and influence the overall risk of someone very significantly. So this is, of course, key. And of course, they tend to cluster. And therefore, it is very important to address them together. Interestingly, also, this very important study called the Inter-Heart study, published 2 decades ago, identified that it's also possible, if you change and modify these risk factors, to change very significantly your risk of developing heart disease. And therefore, it is very important that we recognize the fact that they are modifiable. So collectively, these 9 risk factors listed here, so this is smoking, diabetes, hypertension, lipids, obesity, sedentary lifestyle, they account for approximately 90 to 94% in this particular study, which is a global study, worldwide study, of the risk of someone developing heart disease, especially coronary heart disease. Another way of looking at it was published by Dr. Åkesson from Sweden. She actually identified in a cohort of about 20,000 male participants in this cohort, 5 specific risk factors that influence 80% of the risk of developing heart disease. And they are, of course, once again, additive to one another. They are healthy body weight, being physically active, smoking, alcohol consumption in moderation, and a healthy diet. So this is, of course, once again, very modifiable risk factors that are responsible for almost 80% of the disease burden. So interestingly also, over the last few decades, because in part because they have been identified and targeted for a long time, and we have efficacious medications, there is a decrease, slight decrease, but nevertheless a decrease in the prevalence of these classical risk factors. Some emerging risk factors have been identified to explain why there is a very small reduction in the incidence of coronary artery disease, and they are inflammation, air pollution through microparticles, noise pollution, sleep quality and sleep apnea, stress, intestinal microbiome, referring to the bacteria in your bowel, clonal hematopoiesis. This is the bone marrow that produces blood cells that are senescent. That means they age faster. And of course, there are a number of other new risk factors, but these new risk factors are currently being considered when we talk with someone with limited classical risk factors. And therefore, we have new opportunities to do prevention using these emerging risk factors. So how do we actually prevent? Let's say I would like to separate secondary versus primary prevention. Secondary prevention refers to patients who actually have an event, being a hospitalization for an acute condition or a condition that requires treatment. This treatment is typically high technology, such as percutaneous angioplasty, meaning unblocking blood vessels with balloons and stents. Coronary artery bypass surgery. This is open heart surgery for coronary artery disease, pacemakers, ICDs. And so therefore, if someone requires these treatment, obviously it is very important in the global context of someone presenting with coronary artery disease to have access in due time to these treatments. And of course, there are a number of validated medications that we've just discussed previously. People are typically prescribed these medications and they do better with this treatment. What exactly is state-of-the-art secondary prevention? We've mentioned all these interventions, but in 2019, one of our internationally renowned researchers, Dr. Jean-Claude Tardif, working with us at the Heart Institute here in Montreal, has identified a new therapeutic target called inflammation. This is one risk factor that we have known for a long time when looking at pathology, meaning looking at atherosclerosis through a microscope. We have seen inflammatory cells. We, of course, have never been able before recently to target inflammation and improve clinical outcomes. This has been done in this particular study called COLCOT, and this is using a medication that is very inexpensive, called colchicine. And this study managed to reduce by 23% the occurrence of a bad clinical outcome following a heart attack. So this is very important, and this is one of the only positive clinical trials bringing forward a new therapy for patients suffering from coronary artery disease. This is, of course, very exciting. Now, I would like, however, to bring you to realize that there is actually a residual risk that is not addressed by even the top and state-of-the-art medical treatments, including percutaneous intervention, bypass surgeries, and other important treatments. So, of course, residual risk remains a target for all of us who actually treat patients with this condition or who try to prevent having a heart attack. So how do we address and where do we start from there? We actually look at non-pharmacological interventions. They are oftentimes overlooked and are not considered to their full potential. So healthy foods and exercise are basically the two main components of the non-pharmacological intervention that have been under scrutiny and studied extensively. So what exactly do we mean by exercise? Interestingly, the American Association for Cardiovascular Prevention distinguishes the physical activity from exercise. So physical activity is defined as a bodily movement produced by the contraction of the muscles that results in substantial increase in caloric requirements over resting energy expenditure. So any kind of physical activity is recognized as such. However, exercise is more specifically a subtype of physical activity consisting of a planned, structured, and repetitive bodily movement done with the objective to improve or maintain one or more components of physical fitness. So we will refer to exercise because this is typically what we try to do in the secondary and primary prevention of cardiovascular diseases. So exercise should really be viewed as a prevention and treatment modality for numerous conditions that go beyond cardiovascular diseases, and we recognize neurocognition, so dementia and difficulties concentrating, for example, depression, diabetes, anxiety, chronic lung diseases, cancer, and osteoporosis, among others. So very importantly, it goes across a vast amount of conditions, and it appears to be a very potent approach. So what exactly is the active ingredient in exercise? It, of course, improves muscular strength and autonomy of many people that leads to the improved quality of life so important to the vast majority of our patients. It reduces chronic inflammation, which is also recognized as a risk factor. It promotes the preferential expression of longevity genes through a telomere elongation. It's a bit complicated, but basically, if you exercise on a regular basis, it will select the good genes and leave the bad genes dormant. It also reduces blood pressure, increases good cholesterol, improves insulin resistance, and therefore decreases the risk of diabetes. And it increases the endorphins, so-called the euphoria hormones, making you feel extremely well after you exercise, and basically that improves quality of life. If you are interested in knowing more details about how exercise actually promotes good health, there is a very detailed review in the Nature publication, which is a very well-known medical magazine. And of course, it goes through a very large number of systems and organs that actually produce different substances that have positive effects on good health. So how much exercise do we really need to improve outcomes? It is fairly interesting that with connected devices, we can actually measure the number of steps we perform in a day. This is, of course, something we've done for a long time, and some people have advocated 10,000 steps a day to improve cardiovascular outcome. Interestingly, early this year, January 10th, in a circulation publication, a number of meta-analysis was performed over 8 studies in patients over 60 years old. it looked at how many steps there were and the impact of these steps with clinical and cardiovascular outcomes. So interestingly, if you perform 6,000 to 9,000 steps a day as compared to 2,000, you actually improve cardiovascular diseases by 50% or reduce the incidence of cardiovascular diseases by 50%, a very major contribution to someone's health. Another way of looking at it, another study, completely different study, looking at 25,000 participants in Britain, so UK Biobank, looked at how many minutes a day you should perform of vigorous and intense physical activity, such as carrying your grocery in a staircase, walking up the stairs rapidly, being short of breath in this context, and exercising significantly. Well, as little as 3 to 6 minutes per day of this type of more intense physical activity or exercise will actually lead to a 40% reduction in global mortality. This is very, of course, important. And of course, it reduces the cancer mortality by almost half. So this is very important, again, showing how potent exercise can be in this global context of cardiovascular diseases and global mortality and even cancer mortality. So an important concept also is life expectancy without disability. This is a concept that has been around for a while. One of these first publications happened in 2003, so basically 20 years ago. And the concept is that for most people, although life expectancy is something important, life expectancy without disability, so quality of life related measure, is fundamental and even more important than the actual life expectancy in and of itself. So when we look at patients who actually exercise on a regular basis, it is very clear in the bottom graph that you actually decrease the amount of time that you live with a significant disability. So in patients who do exercise on a regular basis, starting around 50 years old, where most people who don't exercise start accumulating the disabilities and reduce their quality of life progressively until they die. This basically starts more so in the 70s and even 80s. So basically very significant change and decreases the amount of time you actually live with a limitation or significant limitation. So quality of life is dramatically improved if you exercise on a regular basis. This is a fringe benefit that is by no means negligible. So worth knowing, we're not going the right direction. If you look at the World Health Organization reports, it says that basically 3/4 of the adults 18 years older are physically inactive or not active enough. So this is, of course, something that we didn't used to see in the past, and this has been changing in the wrong direction. And the most recent estimates actually mentions that more than 1.4 billion adults are at risk of developing or exacerbating a disease related to physical inactivity. This is something that is, of course, worldwide causing a major concern for future cardiovascular diseases globally. Also, interestingly, very recently, let's say in November 2022, there was a publication looking at how young males and females perform at a test that is standardized, looking at their VO2 max, so basically their physical activity or their physical fitness. In 1992 versus 2017, there is a dramatic reduction below the actual amount that is identified as being the target for the risk of developing future heart disease. And this has been crossed by both in males and females in young age. So we are looking at a very pessimistic future for these age groups. We are very worried, and we are trying to address this issue by influencing as many people as we can to change this at a younger age and do our job as prevention specialists. So for those who are interested, when we prescribe exercise, we of course personalize this prescription. Is different for many people, and we try to address these specific issues that is related to everybody's lifestyle and everybody's schedule. But of course, we use the acronym FIT. This is very easy to remember. Of course, we address frequency, intensity, type, and duration. Ideally, we prescribe exercise at least 3 times a week, but ideally daily. The intensity varies whether you are looking for continuous moderate intensity activity versus high intensity intervals. And if you look for moderate continuous training, let's say you bike or you run for or walk for, let's say, half an hour, the same pace, you should be aiming for about 40 to 60% of what you perceive as being your maximum. And of course, this goes to about between 60 and 95% if you're looking for hits. So you go more closer towards 100% of what you can do. So maximum intensity for short periods of time associated with periods of rest, alternating between high intensity and rest. With regards to the type of exercise, we recommend both the aerobic, meaning cardiovascular when we do exercise, and isometric, meaning resistance training and muscular training, in a ratio of about 5 to 2 in favor of aerobic versus isometric. But if you exercise 5 times a week, aerobic exercise, you should try to do at least 2 sessions of muscular training. With regard to duration, what is typically recommended, and we see the curves for cardiovascular events improvement starting at about 150 minutes per week. This is about 30 minutes of exercise 5 times a week, at least. But if you go up to 300 minutes, it's even better. And of course, intensity is important to address and maintain and get maximum benefit of exercise. In addition to that, we suggest that ideally you have mindful exposure to nature about 3 hours per week if you can, because there are multiple clinical benefits of being exposed to nature, both on the neuropsychological side of things, and of course also with regards to even blood pressure and cardiovascular risk factors. So we strongly suggest you do that. We have incorporated in our routines at the EPIC Center, which is the Rehab and Cardiovascular Prevention Center associated with the Montreal Heart Institute. We have sessions for our clients and patients actually in the park in front of the center to try to promote this idea that nature has a benefit. Now, in a nutshell, at least 30 minutes per day of anything you like. It has to be a high enough intensity to break in a sweat, and you should include isometric exercises, meaning muscular training, also as part of your weekly routine. And you should aim for the park, if at all possible, to try to get the benefits from exposure to nature. So the second part of this lifestyle considerations regarding prevention of cardiovascular diseases, we are talking about healthy eating. And of course, what does it really mean? There's so many information available on the internet, it becomes a little bit blurred sometimes. So we're going to try to deal with this issue and try to address what we think is the best available evidence, scientific evidence to prevent heart disease. So we promote, of course, a global approach to nutrition. We agree with this idea. The Canadian Food Guide, which has been updated recently, 2021-22, has basically followed this idea, and we strongly agree with it. We think it is the best version we've ever seen, so we encourage you to look at it. Of course, it is important. It promotes general ideas such as being mindful of your eating habits and realizing what exactly you do with your food and when you eat and what exactly you eat. This is important, of course, for addressing healthy eating and healthy habits. It's suggested that you should cook more often. Of course, you control better what you put in your food if you cook it yourself. And of course, the fact that you make healthy choices becomes more evident if you cook whatever you buy. Same thing, you should try to enjoy your food, because if you take time to taste it and basically you have a relationship with your food that is healthier and makes sense. And of course, eating meals with others, meaning that this is also a social event when you eat. And of course, this is very favorable globally to address the idea that healthy food is something that you can share with others. Now, what exactly do we mean with the type of food we suggest are healthy? It revolves around what we call the Mediterranean diet. And of course, this is the one diet that has been stood the test of time. It has been extensively studied. We will come to that a little bit later, but also as a mean of explaining it to you, it basically is divided in foods that you should eat every day, foods that you should eat a few times a week maybe, and foods that you should eat on a very unusual basis, meaning only a few times per month, for example. So the bottom line, which is whole grain products, is of course should be the basis of of your diet. It of course is added to these whole grain products, fruits and mostly vegetables, legumes and nuts. This is one partly the legumes and nuts are some of the foods that is less consumed in Canada. And of course, this is one that represents sometimes the most important change when we discuss with patients. As far as fat is concerned or lipids is concerned in your food, in your diet, olive oil is regarded as the ideal fat because it is monounsaturated and it's considered a more healthy fat as opposed to saturated fat. And of course, dairy products, we recommend them on a low fat basis. This is of course more useful. And as far as proteins are concerned in meat, fish is ideal. Poultry is better, and red meat should be limited as much as possible. Eggs also, 2 to 4 a week are recommended. So in a nutshell, in an ultra simplified way, we suggest at least 4 colors in your plate, meaning fruits and vegetables mostly. We suggest olive oil and nuts as far as fats are concerned or lipids are concerned. We suggest to minimize cheese. This is so prevalent. Every time we eat something, it has cheese on it. Minimum meat, especially red meat, and of course, by a suggestion for you to remember what we mean by a Mediterranean is something that has 4 legs is less good for you as something that has only 2 legs, and this is of course less good for you as opposed to something that has no legs at all. So this is important. So this is taken from the Harvard School of Public Health, showing you a representation of what is a healthy eating plate. Importantly, half of it is vegetables and fruits, and this half is mostly vegetables because it contains less sugars than fruit. And whole grains and healthy proteins are divided between the residual half of this plate. So the last clinical trial, maybe the most important one, looking at Mediterranean diet, has been compared to an active control of a low-fat diet. So this is not the usual North American diet. And even so, it has suggested there is a 25% or 27% reduction, I should say, in cardiovascular events. What exactly is meant by the Mediterranean diet? And this is despite, of course, having optimal modern treatments with statins, which are the medications lowering blood lipids. We suggest that there is a 4 or more tablespoons a day of olive oil, 3 fruits, 3 vegetables at least, 6 servings of grains and potatoes, legumes at least 3 times per week, dairy products 2 per day on a low-fat basis. We mentioned it. At least 3 times a week, nuts, which is tree nuts, any kind of nuts is fine. Fish and seafood, 3 or more servings per day, especially fatty fish. White meat, consume more so than red meat and also on a limited basis. Eggs, 2 to 4 units per week. And of course, wine, if you do drink wine, we suggest you have it with your food, and we suggest you drink it in a moderate amount. We don't suggest that people who don't drink start drinking, but if you do, it is part of the Mediterranean diet, globally speaking. So there are variants to this Mediterranean diet, one of which is low carbs, the Mediterranean diet, meaning it's the very same concept, except you decrease a little bit the number of carbs, especially the grains. This is also important in some patient populations who have an issue with glucose management. Of course, another very prominent and very common variation of the Mediterranean is called the green Mediterranean diet, meaning it's vegetarian or mostly vegetarian. And there is the pesco-vegetarian, which of course adds fish to the vegetarian diet. And of course, but it relates the same concepts as the Mediterranean diet also. So there are variants. Interestingly, a brief word on ideal body weight. This is, of course, a subject of significant controversy. There is, however, a very important fact in our minds, and as far as we are concerned, there has been over a number of a span of about 50 years, an increase in the average body weights of both men and women of about 30 pounds. This is, of course, in the same period where there was essentially no change in population genetics. So basically, why is this the case? Is because humans have evolved and have been selected genes in their body that has a tendency to maintain energy and store energy. And of course, we are in an era of unprecedented access to ultra-processed foods and glucose-rich foods. In this context, your body is telling you, despite the fact that you have and you consume lots of these products, to store energy and basically accumulate the energy in the form of fat. Of course, this is extremely difficult also to change, because it is very difficult to sustain a significant caloric restriction over a significant amount of time. And therefore, it is very difficult to lose weight and very easy to gain weight. And therefore, we need to try to find new solutions to that. One of the potential solutions might be a time-restricted feeding as an alternative. What exactly do we mean by that? It is also called intermittent fasting by some. We don't like the term fasting, but it is we prefer time-restricted feeding, because what it refers to really is the fact that you should allow your body to not have access to easy food at least a number of hours per day. So basically, the magic number for us really today has been 16:8 ratio. So therefore, there is a 16 hours per day that your body is not exposed to easy calories and easy sugars. So you basically, practically speaking, we suggest that the patients actually start when needed. It is not referring here, I must admit, to young people. It is not referring to people who have problems with foods, let's say diseases related to food consumption. We are basically talking about patients who are struggling with being overweight. And when we look at, and basically who are overweight in a sense that they also have consequences of that, meaning metabolic consequences and prediabetes or diabetes, for example. So we suggest that people actually start eating after dinner at night and do not eat in the first place until the next morning. This is the breakfast. And this, of course, typically relates to about 8 to 12 hours of fasting. This is natural fasting. And this is the first step. So stop snacking before going to bed first. When patients and people can actually achieve that, of course, we suggest that they may actually increase the amount of hours in which they fast. And basically, they can have, let's say, black coffee or tea in the morning, but don't eat until lunchtime. And of course, when they reach lunchtime, they eat normally lunch and dinner, ideally Mediterranean diet again, don't change the diet at all. And of course, by doing this, they, of course, have access to energy from fat that they actually burn, especially abdominal fat, which is so deleterious to cardiovascular diseases. So interestingly, it is an alternative that we think is more accessible to the majority of people as opposed to caloric restriction. And there are reasons for that, especially when you fast. It does not necessarily stimulate the hunger hormones, such as ghrelin, it's called, as opposed, again, to caloric restriction, which is the typical diets people do when they eat less, for example, without performing this kind of approach. So maybe an alternative. So in conclusions, cardiovascular diseases can actually be largely prevented through lifestyle. So it is so easy, but it needs to start as early as possible in life. An approach based on healthy eating and exercise is key. And we would like you to remember that the Mediterranean diet and exercise should be recognized as treatments, very much the same as medications, for example. And there is also a very important additive beneficial effect on non-pharmacological and pharmacological treatment. This is by no means mutually exclusive. in a sense that if you take medications, it's of course sometimes important and even necessary, but if you add to that a healthy lifestyle, there is additive benefit. Of course, there are also emerging risk factors that should be considered now, and we do consider them, and we do address them with our patients. And of course, we also promote the fact that life expectancy without disability is an important goal of all of our actions. And therefore, we'd like you to remember that this is something or think about it and see whether this is good for you also. Of course, this was only superficial. I've addressed only superficially the entire topic. We have a very good website that is actually promoted that we work on every week. Is very up to date. It's called the Prevention Watch of the Montreal Heart Institute. There is an English version and a French version. It is of course free, and you can look at it. There are multiple articles and even dossiers of all the important subjects in prevention. And I would like you to extend an invitation to visit or even become a member of our rehab and prevention center, where we do this. Practically speaking, it is a gym that has numerous ways for you to be physically active and participate in a healthy lifestyle transformation. So thank you very much for your attention, and I'm happy to try to field a few questions if you have any of those.
Thank you, Dr. L'Allier. I'm going to stop sharing, and we invite you to send us your questions, whatever questions you might have for Dr. L'Allier. We prepared a couple of them, and we will start now if you're comfortable with that, Dr. L'Allier.
Let's try.
Should we go?
Sure.
What is the recommended alcohol consumption for men and women?
Okay, there's been a significant controversy in the global medias recently. There has been a suggestion that we should try to limit alcohol altogether or even stop alcohol altogether. We have a slightly more or a different way of looking at it. When you're looking specifically at cardiovascular diseases, especially the risk of a heart attack, we do look at the literature globally, 5,000 articles, published articles, and even the publications that have been addressed in the recent recommendations. We, however, look at this and see a significant J curve. What do we mean by J curve? Is when we look at the consumption, mild to moderate consumption of alcohol, meaning, let's say, a glass of alcohol for women or 1 or 2 for men on a daily basis, there is basically an associated reduction in the risk of a heart attack. So when this is the case, we think, although this is specific to cardiovascular diseases, let's say, we do think it is important to share this with people. And we do think that the message should be personalized in a sense that the risk should be assessed on a personal basis. If your risk of developing a condition in the future, let's say on the basis of your family history, is related to a significant number of heart attacks in the family, maybe you should be allowed to consider this benefit. However, if, for example, anybody in your family or everybody in your family has a cancer, maybe then it's more important to look at the specific risks. So although this is important to consider alcohol as a significant issue, we do agree with the fact that alcohol can be associated with many bad sides, many bad side effects of alcohol, whether it is in the homes of people, whether it is violence, whether it is car accidents, whether it is falls in the elderly. We, of course, recognize this and, of course, are totally in favor of considering these issues. However, it is a complex message, but it should be addressed on a personal basis. And we see it as slightly differently and should not be a carpet or a global recommendation that has been made recently. We think that there is a benefit of mild to moderate alcohol on heart attacks.
Perfect. So when we address risk factors together, how long does it take to see results? Is there a big difference?
Yes, so there is absolutely a true difference. Thank you very much for that question. These, of course, when we look at the risk factors, especially, let's say, a sedentary lifestyle or a difference in habit, it changes almost immediately. The curves separate immediately, and the benefits are very rapid. In a matter of a few weeks and even a few months, we see a dramatic change. The rehab programs are typically 12 weeks, and the changes that we see during those 12 weeks actually translate into a mortality benefit. So very, very rapid. And similarly, if you change your eating patterns and you start eating healthy, we of course see a very significant change, and the curves start to diverge very early, and they continue to diverge over time. I've shown you the cardio-prev. If you remember the curves, they actually separate early, and of course they keep diverging even years and even decades following the change, so rapidly.
Can we be overweight but have a healthy heart if we exercise?
Okay, it's very important questions. And of course, being overweight in and of itself might be, you might have a transient state in which you don't have a metabolic consequences of being overweight. And if you exercise on a regular basis, absolutely, you can be healthy and fit. But being fit and being healthy is not exactly the same. Globally speaking, if we talk about being overweight, the major risk factors associated with being overweight is developing diabetes or prediabetes and developing insulin resistance associated with atherosclerosis. So it is possible that you decrease all of these risk factors by being physically active and delay the development of diabetes. And therefore, there is a continuum of risk and a continuum of the impact of being overweight, and being physically fit definitely helps.
Thank you. We have a question about intermittent fasting. Can we sustain intermittent fasting on a long term?
So, of course, very important question. We have studies looking at intermittent fasting, looking at the blood results, for example, of people who do intermittent fasting over the long run. And we see sustained improvements in all of these measurements, let's say on the lipids, on the insulin, on even body weight. It basically works. Now, can we sustain it over long term? The answer apparently is yes. We don't have major or large cohorts of patients having done this for a very long time. It is a fairly new concept that has been more so in the general public, and we hear more. So eventually we will do studies, hopefully, to address this question specifically. But right now, we have a significant number of people whom we follow who actually have been doing it for a long time and are doing super well. So we don't think this is something that you should need to do for only a very short period of time. We don't think this could be deleterious in the long term. We have seen no signs of that as of now.
We have a question about diabetes. You keep on talking about diabetes. Is there a difference between diabetes type 1 and diabetes type 2?
Yes, of course. There is a very significant difference in the way diabetes is actually brought forward in someone. Diabetes type 1 is typically called a juvenile condition in a sense that it develops in childhood or early adolescence. It is immunology called basically immunology-driven diseases, and in the fact that the pancreas stops producing the important insulin, and of course someone becomes diabetic because they don't have insulin. Diabetes type 2 is something that becomes a disease more of the adulthood, and of course is related to the fact that there is insulin resistance. So over a long period of time, the pancreas produces too much insulin for a long time. Because of this exposure to insulin, the body normally responds by increasing insulin resistance, and therefore there's a vicious circle of more insulin resistance, more insulin resistance, and of course this develops the consequences of being a type 2 diabetic. So very different, and of course both conditions lead to atherosclerosis, but of course most of my talk today related to adulthood diabetes, mainly type 2 diabetes related to the insulin resistance concept.
Perfect, thank you. We have one question about women's health. Are there any specific prevention data that applies only to women's cycle of life?
Okay, so of course, women have, of course, we have known for a long time that menopause causes a change in the risk profile of women. They basically are somewhat protected before menopause. Of course, when they reach menopause, they basically gain in their risk of cardiovascular diseases and basically reach the level of what men have. So basically in the 60s and 70s, women are almost have a risk profile essentially the same as men. So there is a significant change over their lifetime. Now, with regards to the concepts related to prevention, healthy habits, exercising, etc., all of our major studies have included both men and women, and these concepts are perfectly adaptable to women and men. So that's very important. And similarly, of course, we do have also different numbers associated with men and women due to body size and other factors. But we have specific values that we reach for in identifying, for example, men and women with their risk profiles. But nevertheless, it is the same concept. So basically, globally, the concepts are applicable to both.
Do you have any information or suggestions regarding easy sugar addiction? For example, headaches, withdrawal, suggestions on how to reduce the sugar consumption?
Yes, of course. This is something that we suggest you should do progressively. So in a sense that it's very difficult for someone to have a high exposure to sugar and stop altogether all at once. So especially if you take medications, let's say diabetes medication, we suggest that this should be done under medical supervision or professional supervision of a nutritionist and a doctor, for example, that will adjust your medications according to what you reach as far as limiting your sugar consumption. So we start by stopping the easy sugar access, let's say beverages containing sugar, white sugar that you add to things. So stop adding sugar altogether. And then you go on to identifying what is called the hidden sugar in the general foods and processed foods, but you also identify those as a subsequent approach. So progressive is key here.
Perfect. I think that's all the questions we have for today. Dr. L'Allier, we would like to thank you for being here and taking the time to talk to us about prevention. Thank you for all of you to attending the webinar. We hope you enjoy it. And we will be making sure to send you the link so you can see this webinar that was recorded. Oh, do we have another question? Sorry, I missed that one. Can we lower our risk of heart disease with vitamins and supplements?
So of course, a very good question. Thank you very much for that question. We don't think that the supplements is the way to go. We think that the idea is that the chemistry of food is very complicated and very complex, and many foods have been associated with others in natural foods. So if you try to extract something and give it as a supplement, often you miss the associated elements that will make this food, for example, absorb this vitamin absorbed naturally. So we have not been successful very much with regards to supplements, whether they be vitamin E, for example, vitamin C, for example, or the omega-3 fatty acids. So we suggest that you consume them as part of natural foods.
As in your food nutrition.
Yes.
Okay.
Yes.
That's the all questions we have. I'm sorry I missed that one. Once again, thank you very much. And we hope you enjoyed the webinar, and we're looking forward to hear from you if you have any questions or suggestions. Thank you very much. Enjoy your day.
Thank you.